It's my honor to invite Dr. Girish Bajaj on the stage. Just want to give you a little bit background on Dr. Bajaj. So Dr. Bajaj and me, we go back a long time. We were in medical school together. So we have that strong connection from our old days when we were young. Though Dr. Bajaj is still young and I'm getting older. Dr. Bajaj has done, apart from being a gastroenterologist, he was very passionate about doing further training in inflammatory bowel disease. And the reason is that he has found, practicing in Brampton, that this is one disease which is underappreciated. A lot of our South Asian patients have IBD and they don't have very good options in the community. So he went back and did additional year of training. And I think right now in the Brampton, he's the only one who has a formal training in this complicated disease. He's also working at Mount Sinai, is involved in research and training fellows. And currently, unfortunately, his topic is not IBD. He wants to touch a more, I think, relevant topic in our area as well, which is the celiac disease. So I would like to welcome him to come and share what he wants to share with our audience about celiac disease.
Thank you, Devinder, and it's an honor to be amongst the colleagues and friends. And I believe teaching is and learning. It's a lifelong process, and I love to teach, love to learn. So, anytime during presentations, if anything, I know we will reserve questions for the end. But if you have any burning thing, you can stop me, and I'll be happy to address that. Just one interesting thing about the last talk. Nobody asked about microbiome, gut microbiome role in weight loss. That could be the future. Just telling that. Fecal transplant, fix things. So I'll tell you something interesting. So just keep out a watch for this symptom that a lot of patients will be reporting to you. Bloating. Okay, bloating is part of my questionnaire, and I was almost thinking of getting rid of this bloating thing because 90% people say yes to bloating. But the ones who will really complain of it, just see and ask them if they've gained weight recently. And you will see a lot of people who've gained weight in a short span of time, they complain of a lot of bloating. And there's a gut microbiome role in that. So observe that, ask that question. It will be interesting to see what you find. So, how is it working? Sorry. That's the short disclosure list here. So the objective of today's talk is to learn more about the symptoms of celiac disease. I know you know mostly, but it's just a brush up on what are the symptoms and how do you diagnose management of celiac disease, which is not very complicated actually, not many options in there. And also I will be touching base on H.Pylori diagnosis, its associations with other conditions, and also complications if it's not treated, and the treatment options, which I think is quite important because it has a huge burden on our immigrant community, and so I'll tell you the incidents and all these things. Can you guess what's the diagnosis here? This is, I know it's not the best picture, but these are teeth. No, yeah, reflux can do that for sure. But this is all like, these are cavities, and so dentition. So why I put this on celiac disease, because just to know, celiac disease can present with so many different ways, and this is one of the ways. And sometimes dentists who are aware actually diagnose this disease. If you have too many cavities or something, it's worthwhile to make sure that you don't have celiac disease. So the reason I put it, just to make sure it's a multi-system involvement and it can show. Yes, reflux can do it, but when I do a reflux, I will tell you about when to be careful before you call something reflux. So I'll just put on some cases, and at the end of the celiac talk, I'll discuss what happened next. So this is a 39-year-old South Asian male, just recently seen. This gentleman had a 6-month history of epigastric discomfort, some weight loss and he was feeling full very easily, and his serologies were negative, H.Pylori serologies. Hemoglobin was around okay, not low, it was fine, 130s, and iron was 10, which is still within the normal range. Normal LFTs, normal ultrasounds, there was no past medical history significant, no family history significant, no medications that he was on, physical exam basically unremarkable, and he actually was still quite overweight. His weight was, I would say his BMI was around 29, 30. So the next step. Okay, so I will tell you at the end so you will see what happens. So then this is the next case. So it's a 65-year-old male. He was referred, actually it was a third opinion. He'd already seen to 3 or maybe it was fourth opinion gastroenterologist. And
in the previous case, there was no blood in stools, right?
no stool complaints.
And no family history
Nothing.
of colon.
That's the only history. There's nothing else. Nothing else. I can say a lot of negative things, but there's nothing else. Okay. So this 65-year-old male, he had 35-pound weight loss, and actually I could see because he did not change his clothes, and he was hanging in the clothes. And he had severe anemia and diarrhea for the last 1 year, and he had 2 endoscopies and also had a colonoscopy. Colonoscopy was completely unremarkable. And on the 2 endoscopies, there was severe scalloping. So scalloping is when you see that jagged pattern of the mucosal lining of duodenum, which is quite characteristic of celiac disease. And whence, a lot of the times you may not be even able to diagnose endoscopically, and you depend on the biopsies for celiac disease diagnosis. But when you see scalloping, you can very safely say that this could be from celiac disease. So both the times there was severe scalloping seen, and there was intraepithelial lymphocytes as well. And the reading pathologist both the times said this is quite characteristic of celiac disease. His anti-TTG antibodies were done, and so were the quantitative immunoglobulins. They were normal. And he was put on a gluten-free diet. No improvement. He was quite sick. He lost some more weight. And every time he would come and, we as physicians sometimes, we say, okay, it's compliance issues. You're still eating gluten. And he's like, no, I'm not. So, and that's when he got quite frustrated, and then he came for another opinion. So I asked his wife, asked his family, they're saying, no, this guy is following a completely gluten-free diet, and he is still like that. His past medical history was significant for diabetes, hypertension, hypothyroidism, and he's on metformin, olmesartan, levothyroxine. On exam, he was a very skinny person, and he said, I used to be like really big, and this was very different for him, and there was nothing else in the history or exam. Next step. No travel history. He's had PAN scans. They were all negative. CAT scans and all other causes for weight loss were looked into. Yes. Stop metformin. So actually he was insulin requiring diabetic, and his insulin was stopped, and he was put on metformin because the sugars were now on the lower side. So just to maintain, metformin can be stopped, but he was not having, like the diarrhea was now getting much better as the time was passing by. So metformin can be stopped, but it was actually, I stopped it, but he did not get better. But I did something else as well. And why is that? That's the right answer. That's the right answer, and I'll touch base on that. So that's excellent. Very few people knew. Actually, when I saw him, there was just few case reports. So that's when it was 2 years ago. So now it's a very, very well established thing. So excellent. So celiac disease, basically, it's gluten-sensitive enteropathy, and there is prolamines in wheat. That's a protein fraction. That's the antigen that triggers this antibody formation. And this is also seen in rye and barley, but not in oats. Oats are fine. So if your celiac patients want to eat oats, it's okay. I just put this picture, because this question is asked, and that's why I put it up here. So what alcohol can I drink? So which one? No beer. That's great. How about whiskey or distilled alcohols, vodka? So all distilled alcohols get rid of gluten, so it's fine to drink distilled alcohols, that's fine. Wine is okay as well. Beer, no. Gluten-free beer, sure, you can have. So there are certain genetic factors here, and so HLA DQ2 and DQ8, these are two haplotypes. These are present virtually in almost all celiac patients, and this is where we exploit this and we use it in our diagnostics as well. This is an excellent test to rule out celiac disease. If it's negative, 99% chances this person does not have celiac disease. You can have any findings, but 99% chance. 1% will leave because there are always exceptions, but 99% virtually rules it out. I'll touch base on that. But the thing is, it does not rule it out, rule it in. Why? Because even people who do not have celiac disease can have HLA-DQ28 positive. It does not, so that's the genotype that's associated, but does it translate into phenotype in everybody? The answer is no. So if that genotype is missing, then virtually you've ruled out celiac disease, and especially there are certain situations that you will do, and I will touch Dr. Kapoor's question there. So what happens, there are gliadin reactive T cells, and when they see this gliadin and this gluten coming in contact with with the lining of our gastrointestinal tract, that's when the intraepithelial lymphocytes, they go up in the small bowel, and that's where all this problem starts. Why is it called autoimmune disease? It's an alloimmune thing. Gluten, it's outside. Why do you think it's considered autoimmune? The answer is there because the endomysium also carries there is a cross between the antigens and the endomysium, so that's why that's even though it's an auto, but still it can trigger the immune reaction there. So genetics plays a very important role, and if somebody has a monozygotic twin, then say there's 70% chance the other person also has it, and there is a 10% incidence in first-degree relatives. And recently, there was an article that was published out of I think it was out of England, and they did find there was enough concordance, like enough prevalence in the first-degree relatives that it is now advised or recommended, not still a guideline, that the first-degree relatives may be screened for celiac. That's why I'm saying maybe screened for celiac disease if you find in anybody. So first-degree relatives can be checked. So this is just because we deal with a lot of Southeast Asian patients. So people ask, I did not have this disease in India. I had it when I came here, and it's like, or from somewhere else. But we need to understand this, that the prevalence is quite high, especially in Punjabi population. So Punjabis and Gujaratis, they have, these studies were done in England, and they found that they'd had 2.7 times more often than Europeans. And then another study found Punjabis even more than Gujaratis were predisposed to have celiac disease. And interestingly, similar patterns are being found in inflammatory bowel disease as well, that it's quite common in the Southeast Asian population. And the incidence that we see here in this part of Canada, where there's a high concentration, similar incidence is seen in England, where Indian population is concentrated. So there is some genetic predisposition there. The clinical presentations are head to toe. Dentition I touched upon, we start from that. The first picture is basically, they can be quite anxious, could have depression, kids can present with a lot of behavioral issues. So they may not sleep well, they feel terrible, fatigued. That's one of the commonest complaints is fatigue. This one is that I saw a 74-year-old lady, I diagnosed it last year, and she's still not following a gluten-free diet because she's convinced that she does not have this disease, whereas the titers were quite high and she had villus atrophy. So you can find it in any age group. It can go undiagnosed for the longest time. So diarrhea is one of the typical presentations. Constipation, it can present as constipation too. It does not have to be diarrhea, and that's where we go wrong. We say you don't have diarrhea, you don't have celiac disease. That's not the case. They may be completely asymptomatic from diarrhea standpoint. They can have weight loss. Children can have growth retardation. There could be vitamin deficiency, especially if I see unexplained iron deficiency, vitamin B12 deficiency. I do think of celiac disease. Vitamin D is low in most of the Canadians, so that does not trigger that. Then there are certain atypical presentations, so anemia, dental enamel defects, osteoporosis. They can present with joint pains, transaminases. So workup for chronic liver disease is not complete without ruling out celiac disease. So if you have patients who have high liver enzymes, you should make sure, if you ruled out other causes, that celiac disease has also been looked into. Neurological symptoms. Actually, 50% of your patients may present with the symptoms of peripheral neuropathy. So they may say they have burning in their hands, their feet, and that could be 50% at the time of diagnosis. So this is not an uncommon presentation. So that should ring a bell. They may also complain of burning in their tongue. They can have glossitis, so they can complain of burning in their tongue. The reason is not known. Is it B12 deficiency? Is it but it's thought that it's probably also related to some autoimmune phenomena that involves the nerves. The other neurological is ataxia. Again, that's one of the worst ones to have because that's not reversible even with a gluten-free diet. Rest, a lot of these things will improve, actually reverse with gluten-free diet. Infertility is another one. It can cause infertility in both males and females, again due to unknown reasons, just because there is inflammation, this is an autoimmune condition. So infertility, both sexes can happen, and this is reversible. So if you put them on a gluten-free diet, if that's the main contributor towards their infertility, they will become fertile. And fatigue and depression are very, very common. Then these are some atypical presentations. These are non-bowel presentations. So refractory GERD. And their mechanism of gastroesophageal reflux it could be quite different. And this is more on the basis of dysmotility. So these patients, and these could be the patients who are not responding to your usual PPI therapy. Because of the dysmotility, especially from the small bowel, they can have bile reflux. And that's when they can have this reflux-like symptoms. The cause is bile. It could be acid still, but bile could be another reason. And then if you give PPI, it does not do anything. And that's where you have to give prokinetic agents, motility drugs, to help with the reflux symptoms. Then it can also present with atrophic glossitis, which is burning sensation of tongue. And you will have some people who will be complaining of this. You have no idea what to do next. At least you can check them for celiac disease, so it's something to do. Arthritis, it can present with joint pains. IgA deposition in kidneys. So the interesting thing in celiac disease is that it can cause IgA deposition in kidneys, but it does not activate complements. So the complement factors are not activated. That's why there is no obvious renal damage, but you can see depositions of IgA in the kidneys, but no renal damage as such. Idiopathic pulmonary hemosiderosis, infertility in both sexes, and it can also present with late menarche or early menopause. So it could be an incidental diagnosis. You are looking for something and you end up finding it. And there could be, some people could be silent because they have a latent disease. That means they have antibodies, but they're still not yet manifesting the typical symptoms of celiac disease, just because antibodies are there, but they're still not causing damage as such. And the latent disease can, so you have to keep in mind, so latent means that they have the makings of celiac disease, but they're not presenting right now. And celiac disease can happen at any stage in your life. It doesn't have to be from your birth. It can happen at any stage in your life. So they can later on show up with typical symptoms. Then there are certain disease associations as well. Type 1 diabetes, dermatitis herpetiformis. Patients are complaining of rash on extensor surfaces. It's a very characteristic rash on the extensor surfaces, and it's quite itchy. So if they complain of that itchy rash over extensor surfaces, keep that in mind. Is it always 100% associated with celiac disease? The answer is no. It could be just an entity on its own, but quite a common association with celiac disease, and a gluten-free diet will help there. Eosinophilic esophagitis. I do get a lot of referrals for dysphagia. Just because there's a mention of eosinophilic esophagitis, I want to give you a very simple tip in which you can think of this as that this is a likely diagnosis, and a lot of the time, just from the history, I'm able to say, well, this is a higher likelihood of eosinophilic esophagitis. One is that the eosinophilic esophagitis can be associated with other atopic conditions like asthma, allergies to different environmental antigens. Also, these patients, you ask them a question, are you the one who would keep a glass of water while you're eating? And do you sip water while you're eating? And the answer most of the times is yes. And that's the reason that the diagnosis can get delayed. So if any of your patients is saying, yeah, they are the ones who will keep sipping water while they're eating, And the other ones, because they do it from such an early age, they think it's normal for them. But if you ask this question, if they're saying that, okay, they need investigation, they need to be checked for eosinophilic esophagitis. Then IBD, ulcerative colitis more than Crohn's disease. I have 2 patients in my practice who have ulcerative colitis, both young guys, both have celiac disease. And the reason I picked that up was because they both went into remission with regards to their ulcerative colitis with the treatment, but their anemia was not getting better, and I had no explanation for the anemia. So I ended up doing an endoscopy, and they had severe scalloping, and their antibodies were through the roof. They had celiac disease as well. So once they were put on a gluten-free diet, their hemoglobin normalized. It can also be any inflammatory condition that we know can increase the risk of coronary heart disease, and it can also be associated with myocarditis. Diagnostics, and this is where I'll touch, that's HLA, DQ2 and 8. So these are the different ways we can diagnose celiac disease. Anti-TTG antibodies, they are very sensitive. 95% sensitive and around the same specificity they have. If they are positive, especially in the higher titers, so if between 20 to 30, they're borderline, but if they're above that, they are higher titers. And in that case, they are quite sensitive and specific. The next step for you would be to refer them to a gastroenterologist for the biopsies, because the diagnosis requires confirmation, both the tests, serologies and biopsies, not just on the basis of one test. You do both, because there are exceptions like just we said, olmesartan-induced enteropathy, that can do it. And you can just keep saying that it's celiac disease where it's not. So you have to have both the things to confirm. People who are IgA deficient, this test will go falsely negative. So anti-TTG antibody testing without IgA quantitative analysis is incomplete. So you cannot say that we've ruled out celiac disease because the anti-TTG antibodies were negative. No, you have to also say and make sure that their quantitative immunoglobulins does not show IgA deficiency. And also, let's say if you find that somebody is IgA deficient, they have a higher chance of having celiac disease, and that's when you make diagnosis from other modalities. This HLA DQ2 and 8, it's a very good test. It's a very expensive test, not covered by Ministry of Health. It's a very good test for ruling it out, not ruling it in. So when I do it, there's certain things. So A, like that gentleman I discussed the case, when there's a discordance between the biopsy findings and the serologies with anti-TTG antibodies. So if anti-TTG antibodies are negative and the biopsies are positive, I do HLA DQ2 and 8. And if they do not have the haplotype, it's ruled out. 99% celiac disease is ruled out. B, you do it when patients are on a gluten-free diet and they say they are absolutely not going to start gluten-containing diet. Because if you go on a gluten-free diet, both your serologies and biopsies can go false negative. So those patients who say, I will not go off gluten-free diet, you can ask them, okay, I can do your HLA DQ2 and 8. If it's negative, it's basically rules out celiac disease, but if it's positive, we are back to square one. We may have to put you on a gluten-containing diet. So these are the situations, these are the 2 major situations where we use this. And again, if anytime, any discordance, you're in doubt and you want a test that will rule it out, these are the tests. They're around $200+, $270 something, they're expensive test. Then anti-DGP antibodies. They came with a big roar and they're still there and we still do it. These are IgG antibodies. So if patients who are in IgA deficiency, you can definitely check these, and if they are high, they point towards celiac disease. We still say that they have a quite high sensitivity and specificity, but in my clinical experience, seeing a lot of false positives with that, and we have so I do some research with McMaster on celiac disease, and we have had these conversations where they are also seeing this anti-DGP false positive test. So for me, IgA is the one, and if let's say they have IgA deficiency, so anti-TTG is the one. If they have IgA deficiency or there are discordance results, then I can do anti-DGP. You can still do it, it's fine. If it's very high, then it's positive. But you will see, and I'm already seeing that there is a lot of discordance even in Ig and IgG. The anti-TTG are negative and DGP is positive. So false positives is what we're seeing. I think this test may be standardized even more over the years. So as I said, the confirmation requires combination of the antibodies and duodenal biopsies. I've already touched base. So I want to say where the biopsies are positive, but antibodies are negative. So you have to look at other causes like ARBs. So ARBs can cause enteropathy, and you stop olmesartan or telmisartan, and you can see that it may make a difference. Giardiasis can make the biopsies look similar. They could be villous atrophy. And so I mean, if there is antibodies are negative, make sure the stool is fine. And there can be always false negative antibodies. And due to significant prevalence in the first degree relatives, you can offer it. So let's say, in fact, I do get those referrals sometimes where from the pediatricians that a kid was diagnosed, now they want the parents to be checked. And it's not uncommon that I find one of the parents also have celiac disease. The treatment, unfortunately, is still gluten-free diet. There was a drug that was in pipeline. There was a lot of talk about it, that it will, they will do something that it becomes less antigenic, and it might be fine to have gluten with that. But it really fell on its face. That drug that did not show any significant improvement. So we're back to square one at that it has to be a gluten-free diet. And the 70% patients will start showing improvement in 2 weeks. Some may take a little longer. And women may experience some breast tenderness for the first few months while they are on a gluten-free diet for unknown reasons. And you can reassure them that it's not an uncommonly seen thing, it's fine. You just wait. Why is it important to check gluten-free label for your patients? When you counsel them, you say that you should be, because they will say, I'm having chickpea flour besan or corn flour, makki da atta. And yeah, Nishta. Processed, absolutely right. So in North America, there is a rule that you can put a label of gluten-free only if the thing is processed in a gluten-free facility. You cannot put a gluten-free label until that. And that's why you will see on restaurant menus, they will not say gluten-free, they'll say gluten-friendly because of because of legal issues. You can say only gluten-free if it's done and prepared in a gluten-free facility. And there's enough contamination for that to happen. So you tell your patients to check gluten-free labels. You have to treat nutritional deficiencies aggressively because they can have very bad consequences from nutritional deficiency. So you make sure they're all... So this is my usual follow-up for them. I diagnose them with celiac disease. I counsel them on diet. I send them to dietitians if they're willing to pay because it's not covered by Ministry of Health still. And then I say, okay, go on a gluten-free diet, come back and see me first time in 6 months, then every year. And that's the only routine I do is I check them for nutritional deficiencies. And after a year or so, I also check them for anti-TTG antibodies or an endoscopy to see if the changes have reverted, because if they have reverted, that means they're on the right track, they continue with the same. If they haven't, if I'm sure this is celiac disease, I just counsel them again on diet and send them to a dietitian. Steroids, budesonide, immunomodulators, TNF-alpha inhibitors. These can all be used in refractory cases. I'm touching the commoner part because there is another type of celiac disease which is very severe. It's called ulcerative jejunitis. They're very sick patients, high mortality in those patients because they can have severe problems with absorption and all. In fact, I had a case recently. This lady lost around 50 pounds, hemoglobin was 70, and endoscopy, severe scalloping, antibodies through the roof. And she had some ulcerations in the duodenum as well. Her legs were swollen like this. Her albumin was 20. So we had to admit her, put her on a TPN, and she was started on budesonide, kept in the hospital for good 14, 15 days for nutrition as well as to replenish her deficiencies. I just saw her recently. Her albumin is now 40. Everything has improved. So sometimes you need aid of steroids or other drugs to help. But again, there's a type in which it can be very severe refractory celiac disease, which is basically ulcerative jejunitis, and that's a bad complication because not many treatment options in there, other than the ones I told you. Complications. So, like the lady I just saw today, and she said, I'm fine. Because she does not have major nutritional deficiencies, just slightly iron low. And she said, I want to enjoy my life. I'm fine. I don't want to do any dietary modifications. So you have to tell them, and that's one of the things I educate them on, that if you continue on a gluten-containing diet, your risk of having a malignancy is significantly high. Any GI malignancy, there's more often we see esophageal malignancies wherever the gluten comes in the maximum contact, that's where you see. And you can also see small bowel adenocarcinomas, which are not very common. Adenocarcinoma of small bowel is not very common, but you can see them in patients with celiac disease. So their question is, what if I go on a gluten-free diet? Yeah, then their risk of malignancies goes down to similar as to general population. So this was the second case I spoke about. So this patient had, so I did an endoscopy because he's lost significant amount of weight. There was no dilly-dallying. I get him in to do an endoscopy in a week. I just could not put my scope through between the second and first part of duodenum. There was a big circumferential mass in a 39-year-old male. Biopsies were done and it was poorly differentiated adenocarcinoma. And his D1 showed typical findings of celiac disease, which was severe scalloping. So the antibodies were sent. He had everything expedited. Antibodies came back positive. So this young man had celiac disease, was not known to him. And he presented, his first presentation is with the duodenal adenocarcinoma, which is not a common cancer, and especially at the age of 39. So luckily, he did not have a spread. He had a Whipple's just 10 days ago, and then now he's getting more diagnostic to see if there's any more seeding. Yeah, yeah. He may have had it from birth. And the reason I told that he was not a skinny man. And the one characteristic thing he said, my stomach was always upset as growing up, and I was not a very good eater, but he still had good weight. He's a big guy, but unfortunately this is what happened. His first presentation was with the malignancy and from untreated celiac disease. So the other guy, as we said, olmesartan-induced enteropathy. I stopped his olmesartan. He comes back and sees me. In 3 months, massive weight gain. And actually in 6 months, he gained more than what he was, as Dr. Mehta was saying. You shoot up, and that's what happened. And he was like, I'm happy now, and now because people started making fun of him that he was so skinny. So he gained his weight back. He was back on insulin, and everything was fixed. I did biopsies, endoscopy, everything normal. So keep that in mind. ARBs can cause gluten enteropathy, which is not celiac related. Also, he was 138 hemoglobin. Even with all this adenocarcinoma, he was not very low, 138, 135. And again, a 39-year-old, how many times would come for an annual physical? May not and all. Not necessary. That's the thing. Not necessary. No. That's the thing. It can present with any. So you have to keep a high suspicion. So the only thing he said, he always had upset stomach. Now, should you check everybody who has some upset stomach? That's not the case. The reason I brought this case up was that how important it is to stick to a gluten-free diet. That's the importance here. He had it probably because you have to have chronic inflammation to all these things to happen. So this inflammation was going on probably for the longest time. And this is what happened.
So he was a Punjabi?
Yeah.
So coming to the question, should we as primary physicians screen for celiac in all asymptomatic Punjabis?
No. You have to have a reason. So keep a lower threshold. Let's say, if there's any hemoglobin, low hemoglobin, okay? Yeah, you should. Low hemoglobin triggers a GI consult in almost every male. And females, if menstruation is not the cause, it triggers a GI consult, and we check them for celiac disease for sure. Growth retardation, a lot of dental cavities, or something you're not explained. Infertility, this is a simple test you can do. Somebody comes to you, infertility, you find they are infertilized, celiac disease, fix it. Put them gluten diet, they may save a lot of money from not going to an infertility clinic. So these triggers you have to keep in mind, that there can be some unrelated things that they may present. Peripheral neuropathy, younger person presenting with no diabetes, saying my hands are burning, my feet are burning, tongue is burning. Okay, let's look for celiac disease. Those are legitimate, but not screening for everybody. And there's also something known as non-celiac gluten sensitivity. I just want to give a one-liner on that. They could have a lot of GI symptoms like irritable bowel syndrome symptoms, could be almost difficult to differentiate between symptom-wise between celiac disease and non-celiac gluten sensitivity, only that their parameters will be all normal, their anti-TTG antibodies will be negative, and the main reason we think that it triggers symptoms in those patients is because of the gut microbiome interaction with gluten. It's not an immune mediated. So if they continue on gluten, they'll be uncomfortable, but they will not have any increase in morbidity or mortality.
Is there any evidence to show that if people suddenly stop eating for weight loss purposes for maybe 6 months to a year and then they restart it, then they will become insensitive? Not develop celiac disease, but become insensitive.
Insensitive.
Insensitive, meaning when they eat,
Yeah, yeah.
they get
So
bloating and all those.
that's a full, actually that's a full talk in itself, and weight loss and all this is also my passion, but it's coming to IBS. So in IBS, low FODMAP diet is we generally recommend to patients, and in subgroup analysis and later on studies showed that it was actually gluten was one of the major drivers. So gluten is one of the top ones on FODMAP. So I tell those patients to lower the gluten content but not completely stop and go for gluten-free products, which are highly processed, ultra-processed foods, bad for health. Just today it was published that people who go on a gluten-free diet without celiac disease, they are getting more harm than any good. So I do tell them to lower the gluten content, but also make sure they do not increase other processed foods just to mimic gluten. So you have to put a lot of additives. And I have a huge success rate, I can tell you now. It's a secret that I'm giving out to you, that a big success rate in gas, bloating, and discomfort in these patients. So you can try that. Okay. Again, data is lacking on it, and that's the thing. But sometimes you have to go by clinical experience. Data is there to somewhat support that gluten is one of the top ones in for low FODMAPs, but conflicting data that I cannot put it as a blanket on everybody. All right. So for the time sake, just go on to the H. pylori part of it. Okay. I can do H. pylori in like 2 minutes. I can tell what H. pylori is, but I'll just go a little systematically here. So patients come with a lot of questions with H. pylori, and they are scared to death because of H. pylori, because as soon as they put H. pylori, stomach cancer, cancers pop up on their Google, and they're really scared. So few things to reassure. This infection in endemic areas you get by the age of 2 years. Okay. Then they say, oh, how come I was well so long now? They're 60 years old, 40 years old, and you find H. pylori? Because it can stay silently. It's interestingly, that's how it was explained initially, that this H. pylori, it just loves swimming in the gastric antrum, in the acid and other stuff there, and enjoys its lifespan there. And when there is another trigger or something that adds on, it can cause peptic ulcer, it can cause gastric cancers and duodenal ulcers. So it's in endemic areas, mostly by the age of 2, on an average 10, Canada between 7 to 10, most of the patients will get this infection. Okay. And the mode of transmission is oral, oral-fecal, and 50 to 70% of world's population has this infection. So then, because I also see when a wife is diagnosed, they will check husband, and husband is diagnosed, they'll check wife. Is it really required? The answer is not really, because it's still not a guideline to check asymptomatic patients. And there's more likely that the wife got it from the siblings or school friends or parents while they were growing up, and did not give it to the husband. And if husband has it, it's from his friends. That's a likelihood. So we do not need to really check all the family members, because anyway, there is no guideline right now to treat asymptomatic H. pylori patients. If you find it, because you're doing the test for some symptom, yeah, sure, then treat them. And I'll go over where you should absolutely treat them. So H. pylori loves to live in gastric antrum. So gastric antrum is the last part of the stomach, and just before where the pylorus and duodenum start, it lives there, enjoys its lifespan many years, and we found H. pylori 90 years old, then they present with ulcer. When you give them PPIs, they come up in the gastric body, and that's why it's a technical thing, but when we are doing biopsies, we have to be careful that we take in adequate samples from the antrum and from the body, especially if they're on PPIs. And more than 90% duodenal ulcers are associated with H. pylori. It makes me very nervous if patients have peptic ulcer disease, and if they are not on NSAIDs and they do not have H. pylori infections, I'm quite concerned that something else is going on. And in that case, I check their gastrin levels and other things just to make sure they don't have a gastrinoma or something. So older sayings, ulcers happen from stress. Absolutely not. Ulcers are not from stress. They are from either NSAIDs, H. pylori, gastrin-producing tumors, and other causes as well, vasculitis and all other non-common causes. And 95% of gastric adenomas are associated. Now, then the patients will say, what's the risk of H. pylori and stomach cancers? So 70% of world's population, or 50 to 70% of world's population has this infection. Not everybody is dying of a gastric cancer. So the incidence is still low. It's still not very high. It's only few people out of those will go on to have gastric carcinoma. And one thing I also, being in the community, I can tell, I should not say this statement, that I see a lot of upper GI malignancies in Southeast Asians. Sometimes I think, am I seeing more than colonic cancer? And could be the case. I haven't done that, but I see a lot of upper GI malignancies. So keep a higher suspicion if they're presenting with symptoms. Gastric lymphoma is also quite associated with H. pylori infection. There are certain non-GI associations, not cause. And the difference between cause and association, simple thing, but it's not a cause, it's an association. It can be associated with migraine headaches, coronary artery disease, peripheral vascular disease, ITP. And in ITP patients, a lot of the hematologists will send to us, or they will themselves check them for H. pylori infections, because sometimes treating that takes away ITP and it gets better. Iron deficiency, yes. Why? Because we need acid. So what happens when we have H. pylori infection? The acid production goes down, and when we don't have enough acid, ferrous can get converted to ferric, like all oxidative processes happen, and the iron absorption can go low. It's associated with diabetes. People have put different hypotheses. Stomach is right in front of pancreas. Is there some spillage of something? It's something as a reactive thing, but no concrete evidence still. Chronic urticaria can also be caused. So if patients have chronic urticaria, they have some GI symptoms, yeah, you can look into H. pylori and check and see if treat, and if they get better, sure, you fix them, because treatment for chronic urticaria is pretty bad. They can have Raynaud's phenomena and halitosis. I do get a lot of referrals for halitosis. I say still halitosis still should go to a dentist first, because 2 GI conditions I can think of that can cause halitosis, which is bad breath. One is H. pylori infection. The other one is Zenkus diverticulum. These are the 2 common ones. If you don't find these, I don't waste your time looking into GI causes. You will not find anything. Association with GERD. Is it associated? How many people think it can cause gastroesophageal reflux? When ordered for patients with GERD, we check H. pylori serologies. It does not cause gastroesophageal reflux. You don't need to check their H. pylori. If they're saying they're having, so I just look at the patient, and my question is, where is it burning? Burning up here, below the chest, or burning up in the chest? If they say burning up in the chest, it's GERD, not related to H. pylori. Burning in the stomach, for sure it can be from H. pylori infection. So you don't need to check them. And you can focus on treatment of their gastroesophageal reflux with acid lowering. So diagnosis, it's also very important, and few times I do see that if it was not appropriately checked, and how serologies, unfortunately, Ministry of Health does not cover breath test, and so we rely on serologies. Serologies are like antibodies. Like you're getting a vaccine, you have antibodies, and they will be positive for a long time. Could be for rest of your life, could be for a few months, could be for a few years. And this is what ends up happening, especially if patients have had change of physicians. So somebody checks serology, it's positive, gets treated with antibiotics. Then changes a physician, goes, and again, this was checked for some reason, serologies are positive, again you get treated. So you get treated for positive serologies, whereas it's possible that you got rid of it the first time, and you're getting repeated courses. So if you found serology once, do not repeat it. It's of no use for either refuting the diagnosis or ruling it in. Stop doing it. Just treat them. So again, I would say do not treat on serologies. As a gastroenterologist, we do not order serologies. Very, very rarely. It's when the patient is refusing to pay for $70, $95 for this urea breath test that we say, okay, we'll do serologies, especially if they're from high endemic areas and they've never been treated in the past. Those are the patients, sure, you can treat still basis on positive serologies. But imagine these antibiotics, these are big guns for long duration. What if they cause C. diff and they end up getting their colon taken out? for something that they did not have. So just be careful. So you can order a urea breath test, very sensitive, specific, as good as an endoscopy. And if it's positive, treat it for sure. If it's negative, serologies are positive, this person does not have H. pylori infection. Do not use serologies in low prevalence people. So if you're seeing a Caucasian born in Canada, if you're using serologies and they're positive, there's a higher chance this is a false positive test because prevalence is low. When the prevalence is low, tests give higher false positive. Then you want to go for a test which is very specific. So serologies are not specific, they're sensitive. So you go for a specific test which will give less false positives. So go for a urea breath test. Endoscopy biopsies, excellent. And even sometimes in endoscopic biopsies, if there could be a biopsy bias, and sometimes if I see they have very bad chronic gastritis and I do not find a cause, I may still send them for a breath test, and sometimes you do find that they come back positive, and I treat them on the basis of the breath test and repeat another breath test to see if it's gone or not. Culture is very difficult to do, and that's why we end up treating them empiric. Very difficult to grow and culture these organisms. Stool is a good test, but not available, readily available. We don't do it in Canada. Who to treat? Again, imagine if 70% of the world's population has it and we check everybody and start giving them antibiotics, we'll run out of antibiotics. There'll be no antibiotics left, there'll be no PPIs left. So you have to see. So patients who present with unexplained dyspepsias, abdominal epigastric discomfort, high endemic areas, presenting with anemias, all these patients you can check for H. pylori, and absolutely check in who have peptic ulcer disease, because if you do not treat and they have it, they will have a recurrence of peptic ulcer which can be life-threatening. So active peptic ulcer disease, we don't start them actively because even if they have ulcer, we start them on a PPI, the ulcer heals. And we can let them heal their ulcer and then put them on the treatment at a later time. And history of peptic ulcer disease in the past, and you find infection, for sure treat them because they're still at high risk of having another peptic ulcer. Gastric model lymphoma is no-brainer because they're highly associated, so you treat them. Uninvestigated dyspepsia, so if they are positive for H. pylori, you will treat 15 patients for H. pylori and one will feel better. So that's the number needed to treat. Worthwhile? Sure. Why? Because what else would you do? Resection of early gastric cancer. Yeah, it's H. pylori related. You've taken out one cancer, they can have another one, so you have to treat it. Iron deficiency anemia, because you need acid, intact acid to absorb iron. ITP has association and a good association, so you treat them and see if you can make their ITP better. B12 deficiencies, yeah, because again you need acid in the stomach for B12 absorption as well. Starting NSAIDs in patients who have history of peptic ulcer disease, yeah. Or again, they haven't looked at really endemic population, so if it's a very high endemic population and you're putting them on good doses of NSAIDs and you think they will be on for long duration, in that case you can still check them for H. pylori, because the risk of peptic ulcer with NSAIDs and H. pylori is like 9 to 20 folds. That's so high that you want to treat them. How to treat? This is quite empiric. It's and you cannot remember all this. So let me tell you the pearls here. How to treat? First, never repeat the same regimen. Never repeat the same regimen that has not worked in the past. So if you've put a patient on HP pack for a week, they haven't responded, they come back, do not treat them for 2 weeks HP pack. It's not going to work. You're going to get more of side effects than any benefit from that. So no need to repeat. Second, treatment should be 10 to 14 days. And the new CAG is Canadian Association of Gastroenterology. Their guidelines are treat for 14 days. It's a very resistant infection. Don't treat for 1 week. Don't treat for 10 days. Treat them for 14 days. If they can tolerate, at least 10 days. So I tell my patients, if you're brave enough and nothing bad is happening, take it for 2 weeks. If not, at least take it for 10 days. If you just cannot tolerate, just stop it and come back and look at some other antibiotics. HP pack is our favorite, is that right? It's very easy. Just write HP pack, give it, and it's taken care of. Unfortunately, there is a lot of clarithromycin resistance, and in my personal experience here, practicing in Brampton since 2013, so since 6 years, I'm seeing a lot of resistance to HP pack. I'm not using it anymore as first line. I'm using quadruple therapy based on bismuth. And that's also an indication from CAG guidelines as well that you may look at quadruple therapy because of the higher resistance to clarithromycin, which is part of the HP pack or the triple therapy. Which are the two antibiotics to which basically very minimal resistance is reported with H. pylori? None to minimal. Which are the two out of all the antibiotics here? Which one? Metronidazole actually has a higher, it's a higher resistance. You'll be surprised. It's amoxicillin and bismuth. They're very, very little resistance. So that's why you still incorporate these drugs in different ways. So my first line is I put them on a quadruple therapy, which is bismuth, metronidazole, tetracycline or doxycycline, because tetracycline 4 times a day, doxycycline is 2 times a day, so that's fine, and a double dose PPI. So bismuth, tetracycline, flagyl, and PPIs. That's my first line. Good success rate. More than 90% are getting better on this. If they do not respond to that, 2 weeks, 14 days, no exceptions. So tetracycline, 500 milligrams QID, flagyl 250 milligrams QID. A lot of pharmacists will send you look at your prescription, higher dose advice, 250 QID is good enough dose. Bismuth subsalicylate, 300 milligrams, 4 times a day, and a PPI twice a day. Good response. Let's say if they do not respond, the next step you can go to is levofloxacin and amoxicillin based therapy. So levofloxacin and amoxicillin with a double dose PPI, you can use that. If they're not responding to, they haven't responded to that, now you're in trouble. Why? It's a lot of the times when patients come to me, they've already been tried on triple therapy, so they've done HP pack, they've done a quadruple therapy, and they've done the levofloxacin based therapy. Now what's left? Very few things. Guidelines say at this stage you should do biopsies, culture, and grow. I can tell you from a personal experience, very difficult to culture and grow. We still have to sometimes go empiric. And in that case, rifabutin-based therapy, do not use it as first line. You use it as third or fourth line. So rifabutin-based triple therapy works quite well. Yeah. So you can put that and amoxicillin and PPI, and then they will have I have good success rate. Almost 85% patients are responsive. And they quote in literature around 75 to 85, but who have failed to other therapies, quite well. And the newer one is actually high-dose dual therapy of amoxicillin. So basically you're giving amoxicillin 1 gram 3 times a day and double-dose PPI. These are the rescue therapies that you can give, not as first line. Actually, a Chinese study looked very recently on amoxicillin 1 gram. They had good success. So they're saying it should be used as first line as well, not still as part of a guideline. So we're still using it as a reserve. Actually, with quadruple therapy, very little, because flagyl is quite, and tetracycline. So these are all older antibiotics. Yeah, that they can have diarrhea for sure with the amoxicillin. And that's why I said it's so important that you really know you're treating it. You're not treating a positive serology with no infection in there. Okay. Quadruple therapy? So PPIs are twice a day. Rest are 4 times a day. Flagyl 250 4 times a day. Bismuth 300 milligrams 4 times a day. Tetracycline 500 4 times a day. Let's say if they have actually now a formulation in US which one tablet has all, so it makes it easy for them. So, but not here yet. Again, a lot of the times I'm asked this question: what are the chances I can have? I went back to India and I had this infection again, or something like that. So the chances of once you've successfully treated and confirmed, which can be on the basis of urea breath, I confirm mostly. If I treat it, I confirm. If they're willing to pay $95, I confirm it after a month of completing the treatment. And if that's negative, they've gotten rid of it. Their chances of having it back is less than 1%. So if you've eradicated successfully, that's not the cause of their symptoms later on. Do not waste your time there. It's something else that's going on. And even if it's a recurrence, mostly seen in high-risk professions, gastroenterologists and other people, so who are dealing with these tissues and all. So they are at a higher risk, but not general population. So the pearls I want to give here is be sure serologies should not be repeated. Once positive, maybe positive forever. Treat. You can confirm eradication, especially confirm eradication if they have reasons, peptic ulcer disease, if they've had any malignancy, if they have iron deficiency. All those things you should absolutely confirm. It's a very resistant infection. Do not treat for less than 14 days. in our population here, I'm not using HP pack as often. I'm using more of quadruple therapy. And if that's failing, then levofloxacin and rifabutin based, and that's my go-to. And off late, I'm using in very resistant ones this high dose amoxicillin, and good success rates. And what if you're not able to get rid of it? Too bad. Sometimes you have to leave it alone. You have to, just because you just cannot get rid of it. Yeah, if they have high, you can keep trying, you can do cultures and all, but you have to, at some point you might have to give up. Yeah.
Yeah, a lot of Indian patients, they go back home, so the higher incidence of recurrence, there is that.
Okay, so I'll tell you. So again, you get this infection in childhood. That's the thing. So it's an early, for some reason you get it in your early childhood. It's not a common infection of adults. Second, once you've eradicated it successfully, the recurrence is less than 1% studied. So even if they go back to India, they have symptoms. I haven't found anybody who's I've eradicated, they've come back with something and I've checked, there's no, even like they've been referred to me as recurrence of H. pylori, but I do their test, they don't have it. Yeah. So less than 1%. So you don't need to treat, and if you have a doubt, send our way, we'll take care of that. Yeah.
Clindamycin is not standard on these therapies, and levofloxacin and clindamycin. Okay, so you can use cards or mic.
So the question is whether a combination of clindamycin and levofloxacin is and PPI useful in H. pylori eradication.
The answer is no. We don't use this. It's not a standard treatment. Again, once you fail, you can use any combinations, and I would say do not do it because it's not benign. Gut bacteria plays a major role, and again, even in weight loss, and antibiotics and all are being implicated in changes in weights and all. So besides that, the least benign, one can end up having a colectomy from C. diff colitis, so you have to be careful. So follow the guidelines. Any other questions, celiac or H. pylori? Yeah, so first, if it's, anyway, I'm not using penicillin because as I told you, I'm using quadruple therapy, which does not have amoxicillin, flagyl, tetracycline, and bismuth. So let's say if I failed other, now I'm left only with either load the levofloxacin based with amoxicillin all, then you can get them formally checked for amoxicillin with penicillin allergy, so you can send it to an allergist, and if they do not, because a lot of the time they do not have allergy, then you can treat. But if, and it's bad to have, because as I told you, there are two drugs to which very little or no resistance has been reported. It's amoxicillin and bismuth. So it's very bad if they have amoxicillin allergy and they haven't responded to quadruple therapy. It's hard. And if they have true allergy, then it's a problem. Yes, Dr. Singh.
Would we treat H. pylori with urea breath test positive with quadruple therapy 2 weeks? When should we repeat the urea breath test?
Yeah. So I tell them, so the question is, once we treat somebody based on either on biopsy or urea beta, sometimes you get biopsy, you see the patient even before we have seen in follow-up and you started them on treatment. So once you start on treatment, so you have to wait for a month. So when I tell them patients at least a month, and then you can have it 20 years later, it's fine. But it's not that you have to have it by the end of the month. So you have to wait for a month. And the PPI should be stopped 2 weeks prior to rechecking. So PPI is preferably 2 weeks, if not at least 1 week, because these can give false negatives. So if done within the month of antibiotics, or if they're still on PPIs, it will give a false negative test. So 1 month for antibiotics, 2 weeks for PPI. So I tell them if you start today, 2 weeks and a month, after a month and a half from today, let's say if you start treatment today, you can get the urea breath test, or any time after that. No, they are same. Like, should give adequate actually, and sometimes empirically what we do is we give higher PPI, like sometimes 3 times a day for, like, that's out of the guidelines. That's when this, like us, some subspecialists who are getting referrals for very resistant infections, we do those things too. Because even with a double dose PPI, you still make acid. So you want to really acid deprive this bacteria, because it needs it to break down and to make urea, and also you want to deprive it. So you may use higher doses there. So there's a question in the back. Yes.
I was curious if you generally recommend L-glutamine supplement to help repair the gut lining.
No, and so L-glutamine supplements to repair the gut lining. No, we don't do that. They're like, again, there are some probiotics people are using and all, so we don't do that. Still not part of guidelines, still not studied. One interesting thing I came across is coconut oil. There were some like very small studies in which they found coconut oil was somehow taking care of this H. pylori infection, but not confirmed. So people may ask you, that's the reason. So any other question out of celiac, H. pylori, anything? So now we can all treat H. pylori. You don't need me. That's fine. Thank you.
Thank you everyone for attending this conference. I would like to thank all the speakers who have done an amazing job sharing this information. Would like to thank